So 2021, there was a landmark publication of a new treatment that is called Tebentafusp. You might hear also across market that's called Kimtrack. This type of treatment was the first systemic therapy to improve overall survival for patients with metastatic uveal melanoma that express what we call HLA. So it's HLA directed, which is a peptide that this drug is targeting. So this was the first treatment to improve overall survival and benchmark a new overall survival. So the way it works is that this drug is what we call ImmTAC. So this acronym means immunizing, mobilizing monoclonal antibody against cancer. So this fancy name just to say that this is a bispecific antibody that attracts T cells, so lymphocytes, to kill the uveal melanoma cells. And the way it does is that this bispecific antibody has a receptor that is attracting lymphocytes from your immune system, and the other receptor, the T cell receptor, is targeting what we call a GP100. This is a peptide that is highly expressed in melanoma, for this antibody to work, this peptide GP100 is expressed in patients that harbor the HLA A0201, and this happens across population as well, in heterogeneous ways. When you were looking at data from Caucasian patients to Hispanic patients, this is different, right? But the ranging of patients will be approximately 40% to 50% of the population will express this HLA-A0201, which will allow these patients to undergo treatment with this drug called Tebentafusp, which is what it does is that it attracts the lymphocytes to attack the uveal melanoma cells that are expressing this peptide called GP100. So the most important is that recently, this trial was the what we call phase 3 trial. This was the landmark trial that accrued patients that were advanced, that had advanced metastatic uveal melanoma, and they were tested for HLA, and those patients presenting expressing the HLA haplotype A0201, and of course, some sort of measurable disease, they were randomized to receive Tebentafusp in a dose escalation and stepwise dose escalation compared to an investigator choice in the other arm. So they were randomized 2-1 to Tebentafusp versus investigator choice, which at the time when the trial was running, the possibilities for patients was to receive the classic chemotherapy with the carbazine, or immunotherapy with checkpoint inhibitors, the ipilimumab or pembrolizumab. Ipilimumab is an anti-CTLA-4, and the pembrolizumab is an anti-PD-1. And after randomizing patients, what we learn is that this treatment, the Tebentafusp, patients on the Tebentafusp arm had a median overall survival of 21.6 months, compared to patients treated with chemotherapy or checkpoint inhibitors. So as you can see in this Kaplan-Meier curve, across the time in the x-axis, you can see that the yellow line, it's showing patients in the Tebentafusp arm, and these patients had improved overall survival compared to the control arm, which was chemotherapy or immunotherapy. Another important fact is that what we learned with this trial is that even patients that once they were on Tebentafusp arm and they had their imaging done again, what we learned is that even patients showing a tumor growth by classical imaging, radiographical imaging, using what we call RECIST assessment, even when you measure that lesion before starting treatment and after across the treatment journey with Tebentafusp, and that tumor grew, what we learned is that even those patients show an improved overall survival comparing patients on the investigator arm. So what we learn here, and the key message for patients is that uh, although we still use resist imaging, so cross-sectional imaging in our practice uh, to understand and to make decisions and to understand and to reassess the tumor while patients are on treatment, we learn that radiographic imaging perhaps is not the best way to assess this drug efficacy. And the rationale for that is that because this type of a drug causes a very high local inflammation, accruing T cells, lymphocytes to attack the tumor, perhaps we cannot capture the cell. Actually, the cells dying. However, it's inflammation that perhaps are mimicking a tumor growth. So the way this Tebentafusp drug works is that it works on a weekly basis. So this drug has a very stereotype pattern of side effects, and the way it works is that uh, drawing from the trial, those patients were admitted for their first 2 weeks, and they were receiving the first dose and the first 3 doses as an inpatient, admitted in the hospital, in the outpatient ward, in the inpatient ward, to provide monitoring overnight. And what we learn is that these patients, after the 3rd week as an inpatient receiving this dose, we were able to safely transition these patients for an outpatient setting, where after the 4th week and so forth, those patients can continue the treatment without the need of being admitted. And what do we think, what to expect in terms of side effects? And what usually happens is that it's very common for the Tebentafusp, the way this drug works, to cause a serious side effects, a series of side effects that we expect in a high intensity when you are starting treatment, and such as rash, itchiness. These patients can develop fever, pyrexia, low blood pressure, and also they can develop what we call cytokine release syndrome, which is the acronym is CRS, that is very commonly used across the medical language, is used to show that this drug, when attracting the T cells, it causes a very significant inflammatory reaction, and this is given of the mechanism of action of this molecule. And what is important to see here on this plot is that as time goes by, the rash, the fever, the hypotension, the abnormal laboratory alterations, they decrease significantly after the 2nd to 3rd month. And this is true even when you go after this 3 first weeks as an inpatient. The percentage of side effects markedly decrease. So this and patients overall have a very good tolerance, and we do have very robust follow-up data. And we do know that patients overall have a very good tolerance in long term for this medication.